Hello, thank you for joining us today. My name is Mohammad Najib, and I'm pleased to be here today talking to you all. As someone who has been living with type 1 diabetes for over 33 years and a patient advocate for people living with diabetes, the topic of mental health is very essential. I was unaware of the condition when I was first diagnosed as a child. It took a toll on me when I could not perform regular activities which I could before diagnosis. The questions were too many, but at that age, science was not so advanced for me to be guided effectively or helped in any way except with my family's support. I've lived struggles daily since then to reach a stage where I can now make a difference in mine as well as others people's life. How I stay tuned to my mental health while living with diabetes is simply by acknowledging and accepting that there is some challenge or obstacle that I need to work on, and ignoring is no sign of strength. Being aware of what your body is communicating with you is an essential first step towards tackling this giant of mental health. The thing that I find most helpful in managing my mental health is self talk and a cluster of activities I term ambitious. It stands for accept, acknowledge, being inquisitive, talking or communicating, optimistic, and seeking support when needed. Thank you for listening to my short journey. And with that, it's my pleasure to introduce our keynote speaker, Dr. Jessica Kitchler, who will speak to us about the emotional side of diabetes, including distress, burnout, and self advocacy. Dr. Kitchler is a clinical and health psychologist and associate professor in the Department of Psychology at the University of Windsor. She specializes in clinical intervention research on psychosocial adjustment and coping with type 1 diabetes in youth and families. She worked as a diabetes psychologist and certified diabetes care and education specialist at two academic medical centers, Children's Hospital of Wisconsin and Cincinnati Children's Hospital Medical Center in the United States for almost 15 years before moving to Windsor, Ontario in 2020. Currently, her interest lies in supporting college-aged students with type 1 diabetes, most effectively transitioning into young adulthood. She is also involved in diabetes education practices and appreciates working collaboratively in interdisciplinary settings. And with that, over to you, Dr. Kitchler.
Hi, everyone. Welcome to the emotional side of diabetes, distress, burnout, and self-advocacy. My name is Dr. Jessica Kitchler, and I am a clinical and health psychologist at the University of Windsor and an associate professor in the Department of Psychology. I'm also a certified diabetes care and education specialist registered in the U.S., and I'm looking forward to presenting a little bit today about mental health and diabetes and how they intersect. This is my disclosure slide. So these are the following for-profit and non-for-profit organizations that I've had affiliations with over the last 2 years. And I want to jump right into the 3 objectives I'd like to cover today in our time together. So the first objective is to really understand the diabetes and mental health clinical practice guideline updates from 2018 to 2023. And then the second is to learn a little bit more about how the emotional side of your diabetes care can impact your medical care and your interactions in the healthcare system. And then number 3, I want to spend some time on advocacy and learning how to advocate for your own emotional needs within the framework of these new clinical practice guidelines. So like I mentioned before, our first objective is to understand the updates to the diabetes mental health clinical practice guidelines, abbreviated CPG. So if you hear me say CPG, it refers to clinical practice guidelines. The last version was in 2018, and we just published the most recent version in 2023. And basically what the clinical practice guidelines, it's put out by Diabetes Canada and published in the Canadian Journal of Diabetes. And this is a framework of recommendations and best practices for the healthcare system in treating and working with individuals who have all types of diabetes. And so each of the clinical practice guidelines has chapters, and there's one chapter dedicated to diabetes and mental health. This last chapter was last updated in 2018. And so being that it's been 5 years, it was time to do some updates to those clinical practice guidelines. So we had an expert working group that was filled with psychiatrists, community members, endocrinologists, psychologists, family physicians, and a wide variety of people who have specializations in type 1, type 2, children, adults, and bringing all of their expertise at the table to really update the guidelines from 2018. So this is a brief timeline of when we started to establish ourselves in March of 2022 and all of the different steps we went through to have an evidence review and synthesis team over at McMaster's, our writing time. We presented at Diabetes Canada's professional conference last November, and then it was published in June 2023. So given that that was a couple of months ago, I wanted to spend some time talking to you about these clinical practice guidelines and how they impact you and how you can expect your diabetes care to change or to be enhanced, especially on the emotional or the psychological side of your diabetes. So just as a quick big picture summary, we reorganized this chapter. It was a major overhaul into 14 key messages for people with diabetes. So we don't have time today to go through all 14 of them. What I have done here is I've put in bold the sections that were new and newly added from 2018 to now. So that was stigma associated with diabetes, financial burden, and COVID-19. And then I underlined the sections that were heavily increased and improved and enhanced. And that was diabetes and pregnancy, substance use and diabetes, and the use of psychotropic medications or medications for psychological issues like depression and anxiety, and the intersection between those medications and diabetes management. So this clinical practice guidelines is available on the Canadian Journal of Diabetes website. It is open source. You can go and do a deeper dive into this. But what we're going to do today is I'm going to highlight a little bit on the section on living with diabetes and the emotional side of diabetes, so we can talk a little bit more about strategies that you can use to help you live your best life with diabetes. And then we'll shift over a little bit into stigma associated with diabetes and the financial burden of diabetes, just to really understand how these two situations can really impact your distress with diabetes. So that's where my focus is going to be. But please, now that you know the CPG updates are out there, please go download them, go look at them, go read them. They're long, but there's lots of other information for you to know, and for your healthcare providers too. So like I said, I wanted to start with living with diabetes, the emotional side of living with diabetes. And as you well know, I'm not telling any of you anything new, but just to summarize, diabetes can be stressful, and it's associated with challenges in disease acceptance. So accepting the fact that you have diabetes, whether it's type 1, type 2, gestational, all of the above, as well as treatment acceptance. If you have type 2 and you're sort of progressing along from oral medications to insulin, accepting that is the next steps in your care, and treatment participation, your self-management, all of the daily tasks that you have to do can be very stressful. So we also know that diabetes is associated with increased likelihood of mental health disorders. So stress is one thing, but having a mental health disorder like depression, anxiety, or disordered eating, those are the top 3 clinical disorders that we see at a higher rate within individuals with diabetes. So we know that paying attention to your mental health is very important. And we'll talk a little bit more about strategies to enhance this. What I'm really going to focus in on today is separate from the mental health conditions like depression, anxiety, or disordered eating, is really some of the psychological problems that may not have a clinical diagnosis, but we know are very significant. So the first one being diabetes distress. There's also hesitance to initiate insulin, like I mentioned before, and the fear of hypoglycemia, sort of the anxiety or the fears of going low or having a low, and unfortunate space. But I will talk a lot today about diabetes distress and what you can do to challenge that, because we know more than half of the people with diabetes will experience diabetes distress at some point in their lives. So I want to highlight that one, even though we know that there's way more pieces to the puzzle in terms of all of the different emotional pieces to having diabetes. So let's jump into how can you improve. Let's get some take-home tools of how you could improve your emotional side of your diabetes care going forward. So I'm throwing around a lot of terms, and so I want to slow down a little bit and really spend some time defining some words you may have heard or some terms you may have heard, and people use them interchangeably. And so really picking apart what's the difference. So there's diabetes distress, and then you'll hear diabetes burnout. And so we're going to talk a little bit about what the difference is, and what this chart is over here on the right is a normal curve. And we think if your stress level is very high, then your performance level or your ability to do your diabetes care and your self-management every day, all day, it drops. Obviously, when your distress gets really high, you can get so distressed that it impacts your performance on your diabetes care. But we also know too little stress and being too laid back or too or not worried enough, not worried enough, but not concerned enough or taking it seriously enough. We also know that that can decrease your performance level because maybe you don't see it as that important or as high enough of a concern for you. So we really do like to have this optimal level of your stress. So I'm not here to say, oh, I'm going to take all your stress away. I want you to feel completely relaxed at all times. There's always going to be a moderate level of stress. And that's the place where we feel like that's the optimal level, to have a moderate amount. And that's where we have the highest performance. And you're not so high that you're moving into distress, but you're also not so low that you're too laid back about all of that needs to be done. So that's the backdrop a little bit of when we're using the word distress and what we mean about that stress level being too high or too low or just right in the middle. So to get into the definitions a little bit of diabetes distress versus diabetes burnout. So diabetes distress is really the negative emotions, i.e. the stress that we just talked about on the previous slide, that's experienced by individuals with diabetes, and they can feel burdened and challenged by their care, or they may have ongoing worries and that are associated with diabetes. So it's really that emotional side, that stressful side. And then diabetes burnout is where you feel mentally, emotionally, and physically exhausted by diabetes, and they start to develop some difficulties with your diabetes care, such as avoiding it. Feels so overwhelming that then you sort of push it away a little bit and say, oh my gosh, it's so overwhelming. It's normal human reaction. If something is super overwhelming, if we have a big report at work or an assignment at school, and it's just so overwhelming, we sort of procrastinate it or put it off or try to avoid it a little bit. So that's normal human behavior. But we know when it comes to diabetes, if you start to avoid too much or detach from your support systems too much, because diabetes is so physically, mentally, and emotionally overwhelming, then you have problems keeping up with your self-management and your daily cares, and you feel powerless and hopeless about diabetes. So some ways that you avoid or give up on it a little bit. So distress has much more of the emotional side, but you may or may not still have the ability to keep up with your self-management tasks. But diabetes burnout is you're so overwhelmed that you start to detach and avoid and procrastinate doing your diabetes over time. There was a study that was done that was a scoping review, because even individuals in the research world don't always have these terms very well articulated. But this was a nice article that sort of talked about the difference between distress, burnout, and depression, because they all can overlap but also be distinct. And so they had just a whole host of different descriptive words over here that really lend lent themselves to distress and then to burnout. And this is more of the exhaustion, the apathy, the disengagement. And then the depression is when it crosses over into beyond just diabetes, and you start to become depressed in multiple areas, lose interest, sleep, concentration, all of those things. So it's just a good thing to do, to think a little bit about distress, and then when does it tip into burnout, and then when does it tip into depression. So when we're thinking about you experiencing distress and having high levels of distress, and you sort of say, oh, I'm kind of over that top of that hump of that curve, or you really experience a really high stressor, I want to teach you very specific coping strategies, because I'm sure a lot of people on watching this has seen coping strategies, has read books about it, have done all these different things. And as you know, one size does not fit all. So I can't sit here and say, do this coping strategy and this will work for you no matter what the stressor is. What I want to tell you is we actually have to go back and actually think about the characteristics of the stressor, because not every stressor is the same. Therefore, not every stressor has the same coping response. So rather than saying, oh, if I just go for a walk, that's always going to work, or if I just take deep breaths, that's always going to work, it's not always going to work. And so I have this graph here to really show almost like a choose your own adventure, if you will. And you want to think a little bit more about, what is the stressor that I'm experiencing? What is it about diabetes right now that is stressing me out? Is it that I'm having technology failures? Is it that I'm having lows in the middle of the night? What is it that is causing the stressor? Am I having fear of lows? Am I having worries about future complications? What is it that's really making me feel stressed? So you have to do a little bit of self-reflection. And then you have to ask yourself, do you feel like you can control, and I put control in quotes because, like, really, can we ever really control anything? But can you control the source of that stressor? So if the stressor is, I work out and I have a low every time I'm on the treadmill, that might be something that, oh, I might be able to control that, in the sense that, yes, I could use some problem solving skills to do some different diabetes self-management skills to cope. So before I get on the treadmill, I'm going to make sure I have 15 grams of carbs, or I'm going to make sure I'm running at least at a 5 or a 6 or something, to make sure that if I go low, I have some wiggle room. So there are some problem solving strategies you can do that you all are masters of, oh, let's tweak this, let's try this, let's experiment with this. So if it is a stressor, but it is something you feel like you have a behavioral change that you can do to cope, then yes, use your problem solving skills. But there's sometimes you can't really manage or control the source of the stressor. Maybe the stressor is, even when I run my blood glucose in target range, I occasionally have a low out of the blue, or I do all these things and I have this fear of low, even though I actually have never had a low driving, but I have this fear of it. Well, you can't always control that fear, because you've done all you can problem solving wise to prevent the low maybe while you're driving, but you can manage or control the emotion or the thought in response to that stressor. So you say, I've done what I can to be safe behind the wheel of a car. I can do my deep breathing. I can regulate my emotions. I can tolerate this. I know I'm doing the right thing. I know I'm safe. I know I'm as safe as I can be, and I've done the right thing. So you can do what we call cognitive reframing of, my fear of lows are going to be there, but I've done what I can to manage that fear, and I can do things to cope with maybe the heart racing or the fast breath that is coming because of that emotional reaction. So you may not be able to control and say, okay, I'm never going to have a fear of a low in the future. There's going to be fears of lows at times, but you can manage your reaction to that fear. And sometimes diabetes really can feel like you can't control either the behavior or the thoughts around it, right? So sometimes, okay, I can take a behavioral approach, I can take a thinking and an emotional approach. And sometimes it's just really overwhelming. And it might be a fear of the future or a fear of having to have a more intensive regimen or something like that. And so if you feel like I'm stressed and I don't feel like I can control the behaviors or the emotions and thoughts, then what we want you to do is really engage in what we call mindfulness. And that's where for a short period of time, you get a little distance from diabetes. And this is where you can go for a walk, you can do your mindfulness breathing. There's all kinds of different tools and techniques around even just being in the present moment. There's a grounding technique where you quickly do 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, 1 thing you can taste. So you do something that gets your body back into the here and now and really grounds you. You go out in nature and you look at the different colors. You do a rainbow walk where you try to look around and find 1 thing that's red, green, Roy G, blue, indigo, violet. So you do the rainbow walk. So there are all kinds of things where if you can't do the behaviors and you can't get out of your head, you do things physiologically that get your body and your brain back into the present moment, grounding you in a mindfulness activity. And that gives your brain a chance to reset, decrease the amount of stress hormones that are being released, and help you then go back and focus. Now, you can't stay permanently in distance and mindfulness because then that crosses over to avoidance. But you can go there for a brief period of time just to manage maybe some of the overwhelming thoughts, feelings, and behaviors that are happening. So I wanted to go through the slide with a little more depth so that you could really start to think about what stressor deserves what type of a response, so that you can really design it and individualize it for yourself. So now I want to switch over to stigma associated with diabetes. Like I said before, this was a new section added to the CPG guidelines for 2023. And as many of you have probably already heard, but I will define it for us here. Stigma is the experience of or perceived experience of. So it can actually be an experience where you have it or you're perceiving that it happened. It doesn't have to actually have happened. You can just perceive it, or it could be indirect or direct. But basically, it's experiencing the judgment or the shame that can come along with having diabetes. And so it could be discrimination, it could be shame, it could be judgment. But for some way, shape, or form, others are judging or discriminating or making decisions and assumptions about you based on some characteristic. And here we're talking about stigma associated with diabetes. So you could have social stigma where others may judge the fact that you have diabetes. They may judge that you quote unquote caused it, or they may think of myths about it. So that's social stigma. There's also structural stigma, which comes from systems like the healthcare system might have stigma against individuals with diabetes. Again, they may make assumptions about your physical activity level, or they may make assumptions about how well or not well you're managing your diabetes. So there can be some structural stigma that happens, and especially relevant here is all the diabetes related. So they may make judgments about you because of your diabetes status. And a lot of this can happen around weight and weight-based stigma. That's where a lot of the structural stigma happens too. And healthcare providers are not above perpetuating negative stereotypes about weight and what personality characteristics are associated with weight, which then can negatively impact the patient-provider interactions and communications. And then individuals can start to internalize or have that self-stigma around their weight and shape and their body composition. And so there's been some research out there that shows that not only does this just feel uncomfortable or that this is emotionally damaging and hard, but it also really impacts health outcomes. So there's been some research that shows that individuals who perceive or experience weight-based stigma in the healthcare setting, they have higher levels of elevated cortisol levels, and cortisol levels is the stress hormone that gets released. And when the cortisol levels are released, we know that insulin isn't absorbed as well. And so there's more insulin resistance. So the insulin isn't working as well, higher blood pressure and decreased glycemic stability. So your blood glucose levels go up and down more because of these, or related to, I shouldn't say because of, but related to these patient-provider interactions. So when people are perceiving this stigma, it really does have a health impact as well as a mental health impact. So it's very important that when you notice social stigma, whether this is with people in your immediate vicinity, at your home, at your work, at your school, in your neighborhood, or the more structural in your healthcare system network, we know that diabetes stigma leads to all of these health outcomes, but it also leads to decreased self-management. So if you feel that social stigma of someone's going to judge you at work, you may be a little bit less likely to pull out your CGM on your phone and scan your CGM or do something like that. So you want to be very aware of how diabetes stigma is being internalized by you, and making sure that you don't let it negatively impact your self-management or your other health conditions. And one of the ways that you can do this is really by identifying your support team and really thinking about who is in your network, who do you surround yourself with? Because the research really shows that if you have a strong social support network, it really does buffer social stigma. Now, I wish I could wave my magic wand and make some waiter at a restaurant not discriminate against you or demonstrate social stigma towards you. We can't control society, but what you can control is who's in your immediate vicinity, who's going to help you buffer that, help you improve your outlook and your perspective, increase your self-management skills, and promote these these positive health outcomes. And that really can help offset this. So some of the places that I want you to right now while you're watching this video is to think about think about your social support resources. Is it all you want it to be? Are there people that you need to add to it? You could have people in the inner circle, parents, siblings, friends, romantic relationships, partners. You could have outer circle relationships, healthcare team members who are supportive and not engaging in stigmatizing you, extended family, community, religious groups, diabetes organizations such as Diabetes Canada, blogs, all of social media that are positive. And so typically we think of our social support as coming from our inner circle, but it doesn't always have to be. We don't have to do this. I want you to really be thoughtful about who you get to place in your social support network. We don't have to have the people that are in the inner circle if we feel like they're not actually that helpful of support. So you get to decide which relationships are in your support network and which are in the outer. And oftentimes it's based on who you trust to support you in an effective way. So really spend some time thinking about who do you want to move in? Who do you want to move out? Who's maybe in a little bit, who's in all the way, and think of it as something that can move and change over time, and that you don't just have to accept the people who are in your immediate vicinity if you don't feel like they are supporting you very effectively. So I want you to do a little tree ring exercise. I'm just going to talk you through it. So you can either just keep listening to the video, or you can pause the video for a few minutes and do this tree ring exercise and then come back. But what the tree ring exercise is, I keep talking about these inner circles and these outer circles. I want you on a piece of paper to draw a number of circles. So with you in the middle, and then an outer circle, and then maybe another outer circle, and you can go as far out as you want. I usually suggest that people do 2 or 3 rings. And I want you to physically write down who is in your inner circle of support that you trust, that you find effective, that would help buffer some of the stigma. And I want you to think about, maybe some people are in that very tight inner circle. Maybe some are out a little bit. Maybe it's coworkers, people at work, but maybe your inner circle are people that you see at home or in your neighborhood. And then work is a little bit outside. And then maybe outside of that is your healthcare. You can do it any old way you want, but just spend a moment to actually, in a concrete way, think about your support network. Think about where there might be holes. Think about, wow, I actually have a lot. Think about where you might want some more holes. Think about ways that you can reach out, doing activities like this with Diabetes Canada, and joining and interacting and watching workshops and connecting to other people with diabetes. You could build that up. So take a few minutes and do a tree ring exercise for yourself to really reflect back where your social support network really stands. Okay, and for those of you who paused your video to do the tree ring exercise, welcome back. For those of you who are continuing to watch and will do it later, that's fine as well. I do want to shift gears into another source of distress, since we're really focusing in on diabetes distress, is the financial distress of diabetes. And so we know diabetes is a chronic condition associated with significant healthcare costs. There's both the direct costs, things like the cost of medications, your supplies, if technology is covered by your insurance, if it's not covered by your insurance, healthcare provider appointments, food plans, all of the things, those are direct. But there's also indirect costs. If you have decreased productivity during work during a day because you're managing a severe low, managing the complications where you might have to have extra doctor's appointments and miss more work, or have hospitalizations related to diabetes. So we know there's both direct and indirect costs. And so again, I'm not telling you anything you don't already know, but the clinical practice guidelines really talk about and highlight for the healthcare providers to really put at the forefront how much people living with diabetes are affected by these costs, and how these might impact optimum levels of self-management. So if someone's not able to afford all of the insulin that they need in a month, or if they're not able to afford all of the strips, or they run out and they aren't able to get more, or whatever that is, that these really do impact one's ability, even with the best of intentions to take care of diabetes and do all the self-management tasks. Sometimes access to resources and financial burdens really negatively impact one's ability to take care of diabetes. So your diabetes care team should be regularly inquiring about financial burdens for you. They should be offering some other programs, government, community programs, that they have worked out to help offset some of these costs, because we know that distress, if you don't feel financially stable with your diabetes, how do you have the bandwidth and the mental capacity to manage all of the other pieces of it in terms of feeling overwhelmed with the day-to-day management? So to summarize, how can the CPG guidelines impact your care? With the awareness and impact of diabetes emotional functioning relationships, healthcare providers should regularly ask you about your emotional functioning and your coping and your adjustment. They should be using screening questionnaires. So the CPG guidelines really recommended that that healthcare providers should consider it. They don't require it, but a healthcare provider should be really asking, and or using screeners. And those are little questionnaires that have been validated that ask about your emotional functioning with diabetes. And we have specific ones around diabetes distress and depression and anxiety. And so there's all kinds of different screeners out there. So the diabetes team can also help you manage this distress, use them as a resource. They have lots and lots of strategies and coping and tools that they can help you with, or they can refer you to a mental health services. Healthcare providers are advised, and the CPG guidelines are very clear about having them start to manage and pay attention to their own weight-based biases and their own internalization of weight-based stigma to minimize how much that is then translated to you as their patients in communication, and how much they're sort of aware of perpetuating stigma. And so healthcare providers are also encouraged to inquire and really keep up to date on various supports for the financial burdens, and really help reduce the direct and indirect costs of diabetes by assessing, counseling, and providing resources for you. So in our last little bit, I want to end on objective 3 of talking about self-advocacy. So we talked a lot about different emotional aspects to diabetes, what you can do as an individual to cope, but how do we also look at self-advocacy, and what can you sort of expect and do within these new CPG healthcare guidelines for mental health and diabetes? So, we don't spend enough time, I think, talking about how diabetes also has a silver lining. It also has a lot of opportunity for individuals to build resilience, to have an opportunity to build empathy for others with chronic conditions, compassion. You're building your problem-solving skills. You're becoming adaptable and flexible. You're creative in how you problem solve. You have responsibility for your health. You learn about yourself. You understand how your body's working and what different foods do and exercise. You understand your own strengths, your own limitations, and tolerance for distress or being uncomfortable. So these are all ways that you're building your resilience. And there's also an opportunity for advocacy and being part of something that's bigger than just yourself. So I want to spend a little bit of time on the advocacy part of bouncing back and building your resilience. So I always like to define the terms. When I mean resilience, this is the process of adapting well in the face of adversity, trauma, or other stressors. So this is something where you bounce back. It's not a personality trait. I know a lot of times we'll say, oh, they're a resilient person. It really is a learned behavior, and it's through your thoughts, your behaviors, and your actions. And these are all different ways that you can enhance how you have positive values and positive interactions with the world, developing other talents and interests outside of diabetes, building your friendships and your support networks, education, even if it's not formal education. How are you learning about diabetes? How are you coming to conferences like this? How are you enhancing your knowledge, creating that secure base of who is your support network, who are your people and your place that really make you feel safe and that you're not going to be judged. And then social competencies around dealing with those social stigmas and coping with things that might happen out there with related to diabetes stigma. So how you might self-advocate for yourself is, we know that mood and anxiety symptoms are common in people with diabetes and can lead to more formal mental health diagnosis, such as disordered eating, sleeping. Diabetes distress problems are also common. And so make sure that if your healthcare provider is not asking you about them or is not giving you the screeners, that you are raising these in your diabetes clinic visits. And that when you are being screened, or when a provider does ask you or does give you a formal screener for things like diabetes distress, fear of hypoglycemia, depression, that you fill out these questionnaires and you fill them out honestly, and that you don't hold back or feel like you have to look like you have it all together. Really show what's happening so that the healthcare team knows what's going on and can help you. And then the last piece we want you to do is, or there's a couple last pieces, is if you feel like you are really getting a lot of social stigma, diabetes stigma, or you feel like you're getting weight-based stigma, either in the healthcare system or in society or from others, really talk to your diabetes care team about your social stigma concerns and how you might want to build up your social support network, and speak up if you're really experiencing it in the healthcare system, directly from the healthcare team, because this is a time and a place for all of them to be learning and growing as a society and as a healthcare system. And then we know that caring for diabetes effectively is expensive. So let your healthcare team know if you're having financial burdens, if you're rationing insulin, if you're not doing diabetes cares as much as you want to because of the financial burden, because it's really important for individuals in your healthcare team to know that that's the source of the issue. And so they can help you, but also recognize that you are wanting to do it, but you're having limits to your access. So we've developed a self-advocacy checklist. We have a PDF form of this as well that you'll be able to download. And so as you're going through the checklist, I'm getting ready for your next clinic visit, or as just periodically checking in with yourself, really be aware of how you are emotionally reacting to your diabetes. We talked about the first three, which is why I bolded them: the diabetes distress and burnout, diabetes distress related to stigma, and diabetes distress about the financial burden of diabetes. I didn't talk about all the other host of things, but those are still on there. Check in about your fear of hypoglycemia. Check in on whether you're having some hesitancy or reluctance to take more insulin or to initiate insulin if you've been on oral medicine and you're looking to start insulin. Really looking at reframing that thought of, I need my medical regimen to match what I physically need, and not seeing it as a failure or some sort of way that, you know, you're not doing diabetes well if you have to take more insulin over time, or you have to move from oral to insulin. That really thinking of, this is what my body needs and this is what I need to match, and I'm actually making my body healthier to take the right medicine for what my diabetes needs. So really just using some of those thinking and thought strategies around reframing that. There's issues with how well are you accepting it? How much are you engaging in some of that avoidance and not participating because it feels overwhelming? Are you crossed over into feelings of depression and anxiety that are about diabetes, but then are also about life in general? And making sure you're doing a check-in on that. Looking at your eating behaviors, looking at when are they crossing over into maybe being disordered eating or out of control eating or not enough eating. So really taking stock and inventory and talking to your healthcare team about that. And then filling out any self-report screeners open and honestly. And if you aren't given them, start asking for them. Providers have access to them. Many of them are free, and you can go on, or you can go online, and there are some that you have access to that you can fill out and bring in, or you can ask your team to do it. And then the last thing is, if you and your team decide that a mental health referral is needed to go beyond what the diabetes care team can do to support your diabetes distress and other things, really follow up and find a way to get that extra support so that you are taking care of both the physical and the mental health side of your diabetes. So I want to end a little bit here on just speaking up about diabetes stigma. There's an additional Diabetes Canada webinar on confronting diabetes stigma. So click over here, watch it. If you are someone who really wants to get more involved in standing up against stigma, because there's no such thing as health without mental health. So whether it's stigma about the fact that you're having emotional reactions to diabetes, or stigma around weight, or stigma around feeling shamed and blamed because of difficulties with managing your diabetes, This Diabetes Canada webinar has a great series on learning how to stand up and do more things to stop stigma within our community, and also to stop stigma within our community. And I'll just end a little bit here with making sure that we're not pitting type 1 against type 2. We all have different types of diabetes, and we want to make sure that we're not accidentally stigmatizing type 1 versus type 2 as well. So I'll put that in there too, that little plug in there too, because this webinar talks about that as well. All right, so in terms of questions and discussion, I hope you all enjoyed watching this video, and I look forward to seeing as many of you as I can to my live diabetes dialogue session, which will be Saturday, November 18th from 2:15 to 3:15. I'll be there live to answer questions and have discussion about this topic. And I really appreciate all of your attention today, and I look forward to seeing you on Saturday. Thank you.